The broadcast is now starting. All attendees are in listen-only mode.
Thank you for joining us today. Welcome to Breast Cancer Action's webinar, Inequities in Breast Cancer, Race and Place Matter. My name is Saru Kaiser, and I'm the Program Associate of Education and Mobilization at Breast Cancer Action. On the webinar today, our presenter, also joining us, our other presenter will be Irene Yin, who's an associate professor in the Department of Medicine at the University of California, San Francisco. A few quick announcements before we get started. Breast Cancer Action doesn't take any money from corporations that profit from or contribute to the breast cancer epidemic. Our work is largely supported by individual donors. Please consider making a $25 donation today to support work like these educational webinars. I want to go over a few rules of webinar etiquette before we get started. The presentation of Inequities in Breast Cancer, Race and Place Matter will last about 45 minutes. We'll leave time at the end for questions. Everyone except the speakers will be muted during the webinar to cut down on background noise and to ensure that we can all hear well. If you'd like to ask a question, you can type at any time during the webinar in a pop-up box that should appear on your screen. We'll be keeping track of the questions, and we'll do our best to answer as many as we can, but given the number of attendees, we may not get to yours. You can email us afterwards at info@bcaction.org if we didn't answer your question. If you experience any sound quality issues during the webinar, try hanging up and calling back in. Usually that will fix the problem. You can also call webinar customer support at 800-263-6317. Or if you have trouble with the visual part of the presentation, try closing open windows on your computer and just run the presentation. We want you to get involved with Breast Cancer Action. This webinar is a great way to do that. Please stay tuned for other ways we'll mention later on. So I wanted to start the webinar today talking about the numbers and the effects of breast cancer inequities in different racial and ethnic communities. I'll also talk about the social determinants of health and the importance of race and place. Irene will then discuss the importance of place, focusing on food environments and recreational resources and their implications for breast cancer. Last, we'll talk about health equity, the opportunity to make choices that allow everyone to live a long, healthy life, regardless of where you live, your income, education, or ethnic backgrounds. Breast Cancer Action was founded in 1990 by a group of women who were frustrated with the lack of information about breast cancer. Our founders, only one of whom who is still alive today, knew that their private medical crises were part of a larger public health emergency, and that the experiences of those dealing with breast cancer needed to be heard to address the crisis. Breast Cancer Action's mission is to carry the voices of people affected by breast cancer in order to inspire and compel the changes necessary to end the epidemic. Our advocacy is conducted through a social justice lens because the politics and policies of breast cancer disproportionately affect poor women and women of color. We're going to talk a lot more about that in this webinar. Breast Cancer Action's independence from pharmaceutical company funding puts us in a unique position to address issues of health equity and exposures to toxins in our environment, and to put the needs of patients before pharmaceutical company profits. We have three main program priorities. The first is putting patients first, where we advocate at the Food and Drug Administration in favor of treatments that are less toxic, more effective, and less expensive than those already available. We also provide information about breast cancer to anyone who needs it. The second is creating healthy environments, where we work to reduce the involuntary exposures people encounter that put them at risk for breast cancer by holding corporations accountable for unhealthy products and practices. We also support legislation that would better protect us from chemicals in our environment and would make personal care products safer. And the last is eliminating social inequities related to breast cancer, where we work to create awareness that it's not just genes, but social injustices, political, economic, and racial inequalities that lead to disparities in breast cancer incidence and outcomes. Again, my name is Saru Kaiser, and I'm the Program Associate of Education and Mobilization. I work on educating the public on issues of health inequities related to breast cancer and mobilizing Breast Cancer Action's national partners on inequities issues. Joining me today is Dr. Irene Yin. Dr. Yin is a social epidemiologist with research expertise in survey design and development and qualitative research methods. Her research focuses on the social determinants of health, with emphasis on how neighborhood environment influences health behaviors and health status. She is the principal investigator of 3 projects that investigate neighborhood environment and health. One project focuses on older adults from diverse racial and ethnic backgrounds, and the other 2 projects study how city planning policies and neighborhood environmental characteristics influence the diet and physical activity behavior of girls. So I wanted to start with some general statistics on breast cancer overall. Last year, an estimated 230,000 women were diagnosed with breast cancer, and of that, almost 40,000 will die. Between 1990 and 2007, there was a small decline in breast cancer death rates, which here at Breast Cancer Action we think is not really enough progress. But also really, the rates have not declined equally in all communities, and in some, they're still on the rise. There's also a similar picture when we look at survival rates. And although we recognize that a 5-year survival rate is not a significant marker for breast cancer, many women die 10, 15, 20 years later from breast cancer, we see that white women have a much higher survival rate, 5-year survival rate, than other communities, specifically American Indian, Alaska Native women, and also African American women. And although we see Asian American women having a similar survival rate of white women, this percentage really masks some variation that we see in smaller ethnic populations, and we're going to talk a little bit more about that. So I want to talk more specifically about inequities that we see by racial and ethnic group. But before I do that, I just want to sort of give a caveat that we understand that race is not biologically based, but it's really socially based. But because of persistent racism in the U.S. and its impact on access to education, the ability to earn income, race still continues to be a measure that we use to understand access to health information, screening, detection, diagnosis, and treatment, which is why we're going to talk a little bit about race and also about place. So I wanted to start with African Americans and breast cancer. And many of you may know this fact, and many of you may not, that although white women are more likely to get breast cancer, African American women are more likely to die from it. Also, the Center for Disease Control reported in 2010 that breast cancer was the leading cause of cancer death for black women aged 45 to 64. So we see this lower incidence but higher mortality. African American women also, when we look at younger African Americans that's under 50, we see that they actually have a higher incidence of breast cancer as well as a higher death rate. They also have a lower 5-year survival, which I mentioned earlier. So white women have a 5-year survival rate of 91%, which is pretty high. And African American women have a 5-year survival rate that's 79%, which may be high, but when you look at how much lower it is compared to white women, there's really an inequity there, a real difference. So many believe or come to the conclusion that these differences, these inequities, are really about access to medical care, that must be the only reason. And although it's extremely important that we all have access to health care, it doesn't really fully explain the inequities. There have been studies that have shown that among women with invasive breast cancer, African American women, being insured and having access to medical care does not eliminate the survival disparity for African American women. The other part is that there was a recent study out of UC Irvine looking at the needs of African American women with breast cancer, and really found that the disparities that we saw, the inequities that we saw, were really present in the first few years after diagnosis. That these women, although maybe were satisfied with their treatment, were not being offered support services or access and information about clinical trials. So overall, we're finding that African American women are experiencing disadvantages at every stage of the breast cancer continuum. Now I want to talk about Latinas and breast cancer, and I want to start by saying there's the rates for Latinas, the rate at which they get breast cancer and the rate at which they die are much lower than other ethnic groups or racial groups. But what we do find is a similarity with African Americans in that they're getting diagnosed later and they have a much lower 5-year survival rate. They're also getting diagnosed much younger with more aggressive versions or more aggressive stages of breast cancer. And again, that we still continue to see these differences even when there's equal access to health care with Hispanic women. There's also a limited amount. It says, we simply do not currently have accurate data on Latinas and breast cancer in this country, but we do know that the problem exists. So we see that breast cancer is being diagnosed about 30% less among women of Hispanic origin, and yet it's being diagnosed at a later stage, and therefore the 5-year survival rate is lower, like I mentioned before. And although the incidence rates are lower, we're finding that the rate is increasing over time in Hispanic populations in California. So Asian and Pacific Islander American populations, I'm going to talk in general about them and then break them up because there's a lot of smaller subpopulations that show very different incidence and mortality rates of breast cancer. So the Asian American population is a very diverse population. There's over 37 different ethnic groups that are part of this larger racial category. Pacific Islanders are also part of it, and there's about 25 nationalities that are under the Pacific Islander racial category. So what we're seeing with Asian and Pacific Islander populations is that the breast cancer incidence rates are not declining. So although they have low incidence rates, they're getting breast cancer at much lower rates than all other racial populations, their rates are the only ones that are still going up. Their rates of death from breast cancer are also continuing to rise. So I'm going to talk specifically about some smaller populations, but I think part of it is that when we lump all of these smaller populations into one larger category, we really mask what's truly going on with breast cancer. So this graph shows the difference in incidence of breast cancer, so the rates of women getting breast cancer in smaller ethnic groups within the larger Asian Pacific Islander racial category. And you can see they go very low in Laotian and Capuchin populations to much higher in Japanese and Filipino populations. There's actually a recent study of breast cancer by race and ethnicity in Los Angeles that found that Japanese women have the sharpest rising breast cancer rates over women in all other population groups. Another subpopulation are Samoans. And Samoans have advanced disease and worse cause-specific survival for breast cancer as well as a few other cancers. So again, when we take these rates and sort of lump them all together, it really obscures some inequities that we're seeing in some smaller populations. There's also a real elevated risk of mortality from breast cancer for Samoan women. And there is a recent study that, again, that Samoan women are getting diagnosed at relatively advanced stages and at much younger ages. So again, as I will continue to say, we see that women of color are at an increased risk of dying from breast cancer and are having worse survival rates. Another population that's lumped in the Asian American and Pacific Islander population is Native Hawaiians. Now, Native Hawaiians, the largest populations are really found in Hawaii and California, and so much of the data is focused on these two locations in order to really have a large enough population to study and draw conclusions from. So Native Hawaiians have the highest breast cancer incidence and mortality rates of all other population groups in Hawaii. We also find, as we do with other Asian Pacific Islander populations, that in Native Hawaiian women, the rate of breast cancer, the rate of dying from breast cancer is increasing. So this graph, again, similar to the other one that I showed you, is looking at some specific Pacific Islander populations and showing that, again, Native Hawaiians, the rate of being diagnosed with breast cancer is really much, much higher than even non-Hispanic white women. And this graph, the first graph I showed you was women getting breast cancer, and this is about women dying from breast cancer. And it's showing, this is showing rates in California, and showing that Native Hawaiians have the second highest breast cancer death rates compared to the other populations listed there. Almost right on par with African American women. So the last sort of large racial group I want to talk about is American Indian and Alaska Native women and their experience with breast cancer. Now, like Asian Pacific Islander, Asian American Pacific Islander populations, there's some real differences. There's 575 federally recognized tribes, and each of these tribes have their own language and their own culture, and so there's some real variation. So we're finding that breast cancer is most frequently diagnosed cancer in Alaska Natives and the leading cause of cancer deaths among Alaska Natives. We also know that there's very little data, and the data that we do have is sometimes not as accurate as it could be. There's some large misclassification, racial misclassification. And so a real priority needs to be on improving the data collection and the accuracy of this information. Of all of the ethnic and racial populations, American Indian and Alaska Native women have the lowest 5-year survival rates. They're, I think, roughly around 60%, which is quite low, especially when you also look at their rate of getting breast cancer, which is quite low. And then there's regional differences, which I'm going to talk a little bit more about in the next slide. But that we're finding that the rates, when you look at the whole United States, really obscures some differences when we look at northern versus southern regions of the United States. I just want to say that we've talked a lot. It's been really data heavy, and we have a little more data, and then we're going to get into kind of talking about what this all means. So this map just gives you a visual representation of the regional division of how information is collected for American Indian and Alaska Native women. So it's showing you there's the northern plains and the southern plains, Alaska, Pacific, and East Coast in the Southwest. So we're seeing that in Alaska and the northern plains, there are very, very high rates of rates of incidence of breast cancer, whereas in the Southwest and the southern plains, the rates are much, much lower. When you put these rates together, again, we're obscuring some real important information that's showing us the inequities of breast cancer in this population. This graph is showing the ratio of the amount of women who get breast cancer versus the amount of women who are dying from breast cancer. And so it's showing that in African American and Native American, Alaska Native women, there are less women getting breast cancer, but so many more of those women are dying. So there's a much higher chance of dying from breast cancer if you're African American or Native American, Alaska Native. And this last graph, before we kind of get into the social determinants of health and what all this information means, is showing the death rates from 1988 to 1999 in California. And this is really the most recent data I could find for a 10-year period. So what we're seeing is that the death rate from breast cancer is dropping among all California women. And as you can see, it's very small. But the only population it's not dropping in, and it's actually increasing, is Asian Pacific Islander population. And we're seeing the largest decline in white women, and the declines are much smaller in the other populations. So hopefully you're seeing a trend, and all of this information is really building to a trend of women of color are really presenting with more advanced or more aggressive breast cancers at younger ages, and their rates of survival are much, much lower than white women. We're also seeing that the decline in the rate of women getting breast cancer is much slower than it is in white women, and both of those things is really leading to continuing to increase the gap of incidence of breast cancer and also outcomes of breast cancer between white women and communities of color. So what does all this information mean? And why do these inequities exist? There's a real understanding that your access to medical care and the personal behavior choices that you make are really a small piece of the pie, and that what is really fueling many of these inequities is where we live, work, and play, and the environments in which we live, work, and play that we have options to make choices for better health. So, for example, when we want to choose healthy behaviors like healthy eating or physical exercise, it really assumes that you have the options for healthy food or that you have a safe neighborhood to play. It also assumes that you're not living in a neighborhood where you're being exposed to environmental toxins at higher rates based on the work that you do or the neighborhood that you live in. So that's kind of what this graph is showing you. And again, this quote really gets to that. It says, "Stop thinking of health as something we get at the doctor's office, but instead as something that starts in our families, in our schools and workplaces, in our playgrounds and parks, and in the air we drink, in the air we breathe." So we talked a lot about race when I talked about the inequities, and now I really want to talk about the place piece of it. So solutions to health disparities are likely to be found in these broader societal policy and policy that is not necessarily what we would think of as health policy. It's housing policy, zoning policy, it's policy that shapes the characteristics of communities. There was a study done by Thomas Laviste, I don't know if I'm saying that right, who looked at disparities in Southwest Baltimore when looking at racial residential segregation and the characteristics of the communities. And really what he found was that it's not just race, but it's also place. It's about where people live and about why they live there and how they live in segregated communities and what that means to the resources that are available to them. So why do these both matter? There's the issue of discrimination and racism, which is complicated and really is tied to where we live, whether we live in a neighborhood that is located next to an industrial dump, if we're living in a neighborhood that has beautiful parks and you know, safe places to walk around. All of these things really are related to race and place. And what is the connection between them? I think that as I talked about, the health is really affected by the social and economic adversity, and it's over a person's life course. It's not just about where you're living at one certain place and time. It's really your social disadvantage or advantage and how that affects your options for good health. So the neighborhood environments and breast cancer, and I'm going to talk more about this, but I just want to start by saying that there are aspects of our neighborhoods, the service environment, the social environment, the physical environment, that really impact breast cancer outcomes. And the service environment includes the medical care, the transportation, the supermarkets, the food environments, and the social environment really looks at what is the rate of crime or violence, what do neighborhoods look like. And again, the physical environment is also talking about the environmental pollution or aspects of whether you're exposed to environmental toxins or not. So geographic location is one of the strongest predictors of breast cancer incidence. This is sort of a conclusion that Peggy Reynolds and some colleagues came up with after doing a study looking at breast cancer, regional variations in breast cancer among California teachers. And really, when we look at breast cancer research, if we're looking at focus on individual level risk factors, we're really overlooking the importance of how neighborhood is really shaping the choices that we can make. So I have three kind of areas I want to talk about. There's unequal exposure to environmental toxins. And we know that people of color and people living in low-income or economically disadvantaged areas are disproportionately exposed to environmental pollutants. We also know that for breast cancer, a woman's age at the time of a critical exposure in her environment to an environmental toxin is really relevant to breast cancer risk and breast cancer outcomes. There's also residential segregation. I mentioned it earlier. And racial residential segregation is really about, it's historically based, and it's about certain populations being forced into living in certain areas and in almost ghettoized communities. And these communities have been linked with poor environmental quality, poor housing conditions, reduced access to community resources. And it's really wrong to think about the impact of race in this country without understanding that there are different races that live in different neighborhood contexts where their health risk factors are developed and maintained. And although we see that women living in high socioeconomic neighborhoods have higher incidence of breast cancer, we're also seeing that women living in the poorest socioeconomic neighborhoods are having really low survival rates, which I talked about a little bit before. And the other piece of it is sort of the urban versus the rural. And while many urban areas have higher levels of hazardous air pollutants from traffic and industrial sources, also, on the other hand, rural women are more likely to be working in crops and being exposed to pesticides, or also living in areas that have high level of agricultural pesticide use. So all of these things, the place piece of it that I've talked about, are really what we talk about when we talk about the social determinants of health. And this is a list of, not a full list, but it really, I think, captures what the social determinants of health are. So there are things that I've talked about already about housing and food security, working conditions. It's also about educational opportunities, systems of discrimination. It also has to do with culture and how involved you are in your community. So then the question becomes, why do we continue to have these vast health inequities despite what we know about how social determinants, the large role that social determinants of health play in illness and injury, and why does there continue to be such a disconnect between what we know and what we do? And I think that you know, I don't know the answers. I think that it's a really complex issue, but the first part is really understanding that we can't continue to focus on individuals and individual behavior change, that we really need to look to the larger systemic change and look at the social factors and the ways that where we live, work, and play really affect our health. So what we know about inequities in health, that they're unnecessary, that they're avoidable, and they're unjust and unfair. Like I talked about before, we know that living in a neighborhood where you're exposed, unequally exposed to environmental toxins puts you at risk for, you know, a higher risk of disease, including breast cancer. That's very avoidable, and it's unjust, and it's unfair. Why else are social determinants of health important? Is it because of their indirect effects through individual risk factors and behaviors like smoking? Is it because they also interact with genetic and other biological factors, sort of the gene-environment interactions? Is it because in some ways they're really direct cause of illness? Or is it because of all of these things? And I believe it's because of all of these things. So really we want to start thinking about equity in health and making sure that everyone has a fair opportunity to attain their full health potential. And I'll talk a little bit more about that specific to breast cancer. But for now, I want to turn it over to Irene, who's going to talk a little bit more about specific aspects of place and their implications for breast cancer.
Thank you, Saru. We're going to see if we can hand over control for my piece.
Give it a try.
I just did arrow down. Should I do page now?
I'll do it for you.
Okay, thank you. Appreciate that. So I really appreciate this opportunity to present to you all, and I just want to do a little bit of overlapping with Saru's piece and reiterate how social determinants and breast cancer are connected, just by highlighting one of the more common ways that we look at social determinants in public health research is we look at socioeconomic status. And socioeconomic status is oftentimes income or education. So we know that lower income women are less likely to get breast cancer screening than higher income women. We know that lower SES women are diagnosed at later stages than higher income women. This is something Saru referred to when she was talking about the different racial ethnic differences. And we also know that lower SES women have lower survival rates than higher income women. Then just to move on to talking about one of the key risk factors for developing breast cancer, which can be tied to these broader social determinants and environmental and place circumstances, is obesity. So obesity is, many of you probably know, it's a really serious problem in the U.S. these days. We have childhood obesity epidemic. We have increasing proportions of adults who are obese. And obesity is primarily a combination of diet and physical activity, which we think of as very personal and individual sorts of factors. But we know that they are very much connected to breast cancer. And let's just go over some of the research there. We know that after menopause, obese women are 1.5 times more likely to develop breast cancer than non-obese women. We know that obese women get diagnosed with breast cancer at later stages than non-obese women. And we also know that this is something that is something to watch through the life course, as Saru also mentioned, that weight gain in adulthood is associated with higher risk of postmenopausal breast cancer. So behaviors in, say, the 20s, 30s, and 40s could be associated with breast cancer risk in the 50s and 60s. So I mentioned diet, and then physical activity is another piece associated with breast cancer. And we know from a lot of studies from all around the world that the more physical activity women get, the lower their risk of breast cancer. 60 studies conducted in countries all around the world. Again, referring to life course trajectories or patterns, we know that high levels of physical activity during adolescence might be especially protective in lowering risk for breast cancer later on in adulthood. Oftentimes, behaviors like diet and physical activity also track through the life. So how you behave as a young person with regard to what you're eating and your different physical activities can continue through adulthood. So diet and physical activity sound like very individual, personal choices. Maybe we think of that way. How are they related to place? How is it that place could be an important part of diet and physical activity? And I think that we can look at the food environment, for example, where grocery stores are, where fast food places are, where convenience stores are. That is something that is not necessarily within individual control. Similarly, recreational resources, where is there open space or parks? Close by to where you live, easily to access? Is the area where you live or work walkable? Are there sidewalks so that you can walk around safely, protected from street traffic? When you cross the street, is it hazardous? So those are ways that place could be very important for diet, physical activity, and obesity. And I'm going to just develop some of these ideas, first looking at food environment and then looking a little bit at recreational environments. One of the things that's being highlighted more and more as we look at obesity and the food environment is the concept of a food desert. So this is a map that I've borrowed from the USDA, Department of Agriculture, and they have a food desert locator map. You can get onto their website and put in your address or your zip code and find out if you live in or near a food desert. What is a food desert? It's a low-income census tract where a large number of the people who live there are more than a mile away from a grocery store. So the map shows in darkening shades of this yellow to red areas that are more like deserts as opposed to less. So the darker the color, the higher the proportion of the people who live, who don't live close to a grocery store, I should say. And the USDA recently counted and said that there are 2.3 million, over 2 million people living in our country without a car and without a supermarket within a mile of where they live. So that's one way to look at the food environment. The next slide, I'm showing a picture of the city of San Francisco and showing the food environment in San Francisco. Thank you. And this is another way to look at food environment. So we have different colored dots that label different kinds of food resources. So the green dots are produce vendors, the larger blue dots are supermarkets, the yellowy dots are fast food, and the red are convenience stores. And so we consider the produce vendors and the supermarkets sources of nutritious food, and the fast food and convenience stores sources of less nutritious food. We call them high density, high calorie foods. And this is kind of a smoothing map image to show where are there more good sources of food compared to bad sources of food. And the better locations are the redder locations, and the worse locations are the darker purple or blue locations. And you can see that it varies throughout a city depending on where the different kinds of food stores are. And it is possible with commercial data to characterize where you live this way to look at your food environment. Okay, so now moving on to recreational environment, I borrowed a couple of maps of Los Angeles that were created by an interesting organization there. So the next slide is Los Angeles County, and this is looking at where are the recreational resources in Los Angeles County. So park access for youth. Los Angeles County, as you can imagine, is quite large. And what this map is showing is that the pink areas that are just solid and light are highlighting where the youth are concentrated in the county of Los Angeles. And then the areas that have the darker red outlines around them, and that have kind of hash marks, or I should say that are more kind of shaded or dotted, those highlight areas where there are both a higher concentration of youth who are also living over a half a mile away from a park. So as I mentioned, where recreational resources are located in an area isn't necessarily a random occurrence. It can be decided by government, by local resources where they can invest money in places. And in Los Angeles County, there are a lot of young people who don't live anywhere near a park. So the next slide, the same organization looked at the connections between where youth are living, open space, and also obesity. And my computer has gotten really sluggish, so if you've advanced the slide, I can't see it yet.
Oh, I did.
Okay, great. Now I see it. Thank you.
Sorry.
So, no, not at all. So this is, as I mentioned, this is overlaying obesity on where the parks are, and the cross-hatching, the diagonal hashing is showing where there are high proportions of obese children, and it quite corresponds closely to also where there aren't so many parks. So the darker the red, the fewer the parks per 1,000 people. So I think these are ways for you locally, if you're interested in bringing this to the attention of key stakeholders and community and political leaders, to talk about how can your environments be designed in a way that's more supportive of physical activity, being able to have access to affordable, nutritious foods. You can document the circumstances in which you're living and working to these people who have control and influence over resources. So the next couple of slides, I just wanted to talk a little bit about research that I've done, where I've tried to look at the connections between how places are designed and physical activity. The next slide is one example of some work that I've done, which Saru mentioned in the introduction of me. I've done some work on a project called the Signet Study, which is a study of 7-year-old girls being followed for 10 years. It's a very interesting study looking at environmental exposures and the girls' transition through puberty. Let's see, I am also not seeing the slide yet on my screen.
It must be really slow. I progressed it quite a while ago.
Yeah. No, my computer seems to be having a technical problem. Sorry about that. So I can see what I'm supposed to be talking about. So I studied 215 girls within the Signet study, and I used a street audit tool, which is a way to go into an area and observe the neighborhood. That I sent in observers to rate what they saw in the neighborhoods, and some of the things they looked for was the land use environment. Were there residential buildings, commercial destinations? Were there government buildings? Were there recreational facilities? What sort of transportation environment was there? Were there bus stops? And then other kinds of facilities. I looked also at recreational resources, parks and playgrounds, and physical disorder, which is graffiti, litter, trash, that kind of thing. And then the next slide shows you some of the things I found from looking at the kinds of neighborhoods that the girls were living in, ascertained by the street audit tool, and then if there was a connection between what resources they had and physical activity levels. So I collected a lot of data with the street audit tool, and I collapsed some of these data elements into something I called recreation, which included if there were complete sports equipment in the play areas, if there were street shoulders or wide outside lanes, what kind of traffic control was there, and were there traffic circles or roundabouts, and if there was playground equipment in the play areas or the schoolyards. And I found that this recreational measure was associated with physical activity for the Latino girls, not so much for the non-Hispanic white girls, however. We're not quite sure why there's a difference for the different ethnic groupings. One possibility is that the neighborhood recreational environment might be more important for the physical activity level of the Latina girls than for the white girls, because maybe the white girls had access to other resources outside of their neighborhood. This was a Kaiser patient population group of girls, and for the most part, a little bit higher income than your national average, although this is San Francisco Bay Area, and the income levels are higher here because cost of living is also higher. So there isn't, it's not necessarily a correlation, direct correlation between ethnicity and income, but that's one possible explanation. And it goes to the explanation that Saru was suggesting for how race and place are connected, or race and social and economic status and resources are also connected. So the next slide is some findings from another project that I did, which was focus group study of mothers of children in another part of California, where we were talking to the mothers about their neighborhoods and about their food resources and recreational resources in their neighborhoods. And what we found in looking at and what they said is that depending on the area where people live, something that you might think of as a resource may not be a resource if the area is threatened or challenged in other ways. And so the example I wanted to show today was with regard to parks, that parks don't play the same role necessarily in every neighborhood. And we talked to people who were low income, who were on public assistance, and we also talked to people who were middle income. And for the most part, the lower income people lived in lower income areas, and the middle income people lived in areas that were higher income than the lower income areas, so to speak. And so I wanted to show some contrasting quotes about parks from these two different sorts of areas. You know, for example, my husband practiced soccer twice a week. He would say, come and bring the girl. And that's their daughter. All of a sudden, I don't know if it was because there were not so many men. They were not going to exercise. And my daughter, she's 8 years old, she starts asking many questions. Mommy, that guy is doing pills. Mommy, let's go to the other side. So this was translated from Spanish, and what we understood from what was being said in the focus group was that this was a park not far from where they lived, and the man would go there regularly to play soccer with his friends. But when the mother would take the daughter to go watch the soccer games, they would also see other things going on in the park that they didn't think were as appropriate for their young daughter to be seeing. And so the park is an open space play area, but it also could be a place where other kinds of activities are going on which are not for children. In a higher income area, though, somebody else said, well, now that they've revamped the parks, they're being way more utilized. It's nice to drive by and see children and their parents playing. Before, they were just rusty. That's referring to the playground equipment or the play equipment. It wasn't in good order, and so people didn't go, according to this person. But you know, somebody, someone, some entity replaced that and has revamped the parks, and so now it's being used, and this is a positive. It's a benefit. So those are some examples of some work that I've done that have looked at place and health connections. And then I just wanted to talk about city planning and how that can contribute to how places are designed, and how that can contribute to the environment in which people live, work, and play, and why that can be relevant to diet, physical activity, obesity, and ultimately breast cancer risk. So you can understand the role of place, and then once you understand that, you can try to make design interventions that could ultimately support or maintain health better. And some of the ways that I think that's possible is by looking at the mix of services that can be in an area. So you can have residential near services, or you can have grocery stores closer to where people live. Another thing I've mentioned is, how traffic is controlled. The amount of traffic. So that could be related to posted speed limits, how the traffic is managed, if there's traffic lights or stop signs, speed bumps, and then if there's labeled crosswalks for people. The other thing that city planning can look into and contribute to is other infrastructures such as benches or public restrooms or street lights. So Saru also asked me to talk about some key legislation that is at the national and local level that's relevant to how environments are designed. And the examples that I wanted to talk about today were the transportation bill. The federal transportation bill is a very large bill. It gets renewed every 5 years. Right now it's actually overdue, and it's making its way through committees in Congress, and is very relevant to safe routes to schools, walking school buses, for making sure kids have opportunities to get out, but also funding for bike lanes and for sidewalks, and certainly also for highways and the design of streets and roads. The Farm Bill is also really important for food pricing, for food accessibility, and that's due to be renewed this summer, and there's already activity in Washington around what sorts of contents are going to be in there. And the last one was Complete Streets, which is legislation at local, state, and national levels to make sure that streets are designed to be safe and accessible for people of all ages and abilities. So this next slide, or maybe you're on it already, I'm still experiencing a delay, it explains what complete streets are, but also lets you know that it's actually something that's spreading out throughout the country, that already 26 states have state-level complete streets policies, and that over 350 local towns have also adopted them. And the next step for this work is for there to be implementation of these policies, because having it on the books and implementing it are two different things. So I think I will stop there and hand it back over to Saru.
Thank you so much, Irene. I think your presentation was really great for really talking about moving beyond personal behavior choices of diet and exercise and looking at how food environments and recreational resources are really important part of understanding social determinants of health and breast cancer. It's also by looking through a social justice lens that we understand how other characteristics of place, like what I talked about before, unequal exposures to environmental toxins, also really affect different communities' risks for breast cancer. So our vision for the future, or kind of to wrap up the webinar, is that, as I talked about before, we're seeing a lack of data, or data that's just not as accurate as it could be on inequities in some communities, and that we really need people's experiences to help inform what that looks like. We also need to continue to understand how place is related to health, but it's also related to the unequal exposures to environmental toxins, and that toxic conditions in neighborhoods can negate any individual effort that someone might have to eat better or exercise. And hopefully the message you've heard through this webinar is that racial and ethnic minorities are getting aggressive breast cancer at early ages and dying at higher rates. And although, as we said before, that 5-year survival rate is not a complete picture of breast cancer survival, many women in communities of color are not even living to 5 years. So we really understand that the ability to access the same standard of care for breast cancer is important, and it also doesn't stop there, that access to health care alone will not stop the breast cancer epidemic and the inequities that we see in breast cancer. We need resources that will help us understand the root causes of breast cancer and stop the disease before it even starts. And again, your neighborhood or your job shouldn't be hazardous to your health. As we mentioned before, this concept of health equity and really having the opportunity to make choices that allow everyone to live a long and healthy life regardless of where we live, our income, our education, or our ethnic backgrounds. And when we talk about healthy environments or healthy places of work, we kind of go to the precautionary principle, which really works to protect everyone by promoting chemical safety testing specific to vulnerable populations, and also communities that have an unequal exposure by where they live and also by where they play and work. So as a national grassroots education and advocacy organization working to end breast cancer epidemic, we will always push for systemic change and really shift the burden off of individuals and focus on structural changes in society. There's a really good quote that I like from David Williams at the Harvard School of Public Health, and he says, "Increasing job opportunities, providing education and training for better jobs, investing in our schools, improving housing, integrating neighborhoods, really giving people more control over their work. These are as much about health strategies as diet, smoking, and exercise." So again, the part of that I think is so important is that systemic change and really making structural changes in society. It's why we work with a coalition of organizations pushing for regulatory reform through the Safe Chemicals Act, which focuses on the EPA and chemical reform, and also the Safe Cosmetic Act, which focuses on the FDA and personal care safety. And again, there's this idea that we really can't push individual behavior change without linking it to the larger policy and systemic change. We know that that doesn't work. So we're going to open it up to your questions in a few minutes, but I just wanted to talk a little bit more about what you can do and how you can get involved. You can become a member of Breast Cancer Action. You can sign up for our news and action alert emails to keep up to date on the issues. You can also join us on Facebook and Twitter to connect with others and help change the conversation about the breast cancer epidemic. Also, you can share this information with your friends. Maybe this webinar was new to you. Maybe it's just confirmed what you have already known. But the next step is really helping others get involved. Tell your friends, your coworkers, your family about this webinar and why it is important to you. You can also, I hope the information in here has really given you the tools to really think about and question when individual behavior change is presented as a solution and there's no policy or larger systemic change linked to it, that you can question that and call people and organizations out for that. Lastly, you can donate to support our education and advocacy work. I want to talk about a few further resources and places that I found much of the information that I put together for this webinar. The Asian and Pacific Islander American Health Forum is a national health policy organization for Asian American, Native Hawaiians, and Pacific Islanders. And they have a lot of really great information around health and specifically some great information about breast cancer and how it is affecting different smaller populations within that larger racial category. I also, again, want to put in a plug for Breast Cancer Action. We're a great place to find information as well as engage in discussion on many of the issues that we've talked about today. This is the Facebook page for Complete Streets that Irene spoke about. If you are interested and want to find out more information, you can go to that website. There's also a resource called, that many people might know about, Unnatural Causes, which is a documentary series exploring racial and socioeconomic inequities and inequalities in health. And it's a really great resource, and they have a lot of good references and other resources on their page. And last, specific to Native American and Alaska Native women, who seeks to help reduce cancer incidence and mortality in the Native American and Alaska Native population. Again, I want to remind you that Breast Cancer Action relies on your support to make these webinars possible. Your individual support of our work is crucial. If you've been inspired today, please consider making a donation of $25 or more so we can continue these webinars. You can go to www.breastcanceraction, breastcanceraction.org/donate. I want to give a big thank you to Irene Yin for her presentation today, and now I'd like to open it up to any questions you might have. A few people have been typing in questions as we've been presenting the webinar, and I will try to address some of them. Okay, so someone asks about getting a copy of the presentation. All of our webinars are recorded and posted on our website about a week after they air. So probably middle of next week, you can go to our website, and under Resources and under Webinars, you can find this webinar along with all the webinars we have done in the past. Also, I just want to say with that, following the webinar tomorrow, which will be a repeat of today, I will be sending an email to everyone who attended and didn't attend with some follow-up information, both a survey to complete and also some of the information for resources and other ways to get involved that we presented today. Someone says, should we be, quote, calling organizations out or using this information to educate and challenge our friends, organizations, etc., to look at all areas of causes and solutions as we try to reduce the incidence of cancer and increase mortality? I would say yes. I mean, I think there are organizations that are doing really wonderful work around addressing individual behavior, and I think that many of them also link to policy change. It's not just about reducing smoking, but it's about national legislation around cigarettes and smoking. And so I think there's a real distinction between organizations or people who talk about, people just need to change their behavior, and things that are supporting people in changing their behavior, as well as creating environments that are more conducive to making those changes. I think that's a really great question. Thank you. Let's see. Are there any solutions for providing good nutrition in a way that is accessible to socioeconomically, I'm assuming lower socioeconomic women? I think, I don't know if, Irene, you want to say anything about this. At Breast Cancer Action, we're really focused on how do we make policy, how do we support policy changes that give women choices rather than focus on how someone can, have good nutrition and an individual. Irene, I don't know if you want to address that.
I'm curious about if the person can say if they're living somewhere where they're in a food desert, for example. I think the perspective of our presentations is to look at if there's a way to organize to get a full-service food store nearer to you if access is an issue. Usually a larger store will have more choices, and so there's the possibility to have access to the affordable and nutritious variety. Mm-hmm. But I don't know if that's where this person was, what they were getting at when they asked their question.
Right. Yeah, I'm not sure. I think it says that they're not living in a food desert, but know many friends whose closest grocery store is a convenience store like 7-Eleven.
Right. So I also wonder about advocating for this to the store owner if it's a single small business owner as opposed to a chain convenience store. If there's a way to actually for the neighborhood or the people who live close by who would shop there more if there were better inventory, to go to the store owner and say, we would come here if you would stock these things. Then it would be a win-win.
Right, right. Someone asks an example of an intervention that links individual behavior with larger policy or systemic change. And I think the example I would give are around the work that we do in environmental areas looking at the Safe Cosmetics and the Safe Chemicals Act. So I think there's a real push for sort of this conscious consumerism of getting people to really look at their personal care products and not to buy things with parabens or phthalates. Or, but when you link, and I think that's important. People need to know, need to have the information so they can make their own choices. But in order for everyone to have the same access, for people who can't afford to make those choices, we really need to push for larger federal policy like the Safe Cosmetics Act that is going to make personal care products safer for everyone, not just the people who can afford it. Let's see, some other questions. Someone says, Asian women have a lower blood estrogen level, have breast cancer at younger ages, either in U.S., Japan, South Korea, and China. Is this all related to lifestyle or genetic predisposition and lifestyle? And I don't know the exact answer, but I can tell you that there's definitely studies looking at Asian populations and immigration and their rates of breast cancer. I think a lot of those studies are giving more cause to looking into environmental causes of breast cancer. And when women's breast cancer rates are increasing the longer they've been in the United States, it's also showing that depending on when a woman comes, if she comes earlier versus later, there's issues of when is she having exposures to potential environmental toxins that are increasing her risk for breast cancer. I don't know about the blood estrogen levels, though. I'm unfamiliar with that. Someone asks, have you looked at black hair products that purportedly have extremely toxic chemicals? We don't look at I think, again, it's not a matter of product by product. But we did have a webinar in November that looked at toxic cosmetics and really explored what the landscape looks like and what reform is necessary. And we talked a lot about the Safe Cosmetics Act, which really is working to make personal care products safer for everyone by helping the FDA do some better regulation. And there definitely is a larger burden on African American populations because black hair products do have extremely toxic chemicals. But again, it's a matter of trying to work towards policy for everyone. I didn't. How do you, someone else says, how do you explain higher rates of triple-negative breast cancer subtype in African American women versus non-African American women? I would say that just from what I've seen, and it's not one single disease. It's I think the study most recently showed that there were, I think, over 10 different diseases sort of under the breast cancer umbrella. And so we don't know why different populations are affected by different types of breast cancer. But I think one potential reason is really looking at where we live, work, and play, and where are African American women living and working that is potentially exposing them to environmental toxins or the resources that they have or don't have that are showing in this higher rate of triple-negative breast cancer. So we've gone a little bit over, and there's some really amazing and wonderful discussions and questions going on. I think we're going to wrap it with that question, and I just want to thank everyone who's been on the webinar today. And hope that this has been interesting and informative. And thank you for your questions and comments. And again, if we didn't have a chance to answer your question or you have more to say, please follow up with us at info@bcaction.org. Again, thank you so much for attending, and please watch your email for a short survey where you can provide feedback on this webinar.